Good morning, good afternoon, good evening. I'm very honored to welcome you to this special MOH Medical Online Hub that is fully dedicated to the upcoming Venous Symposium Europe, taking place in Athens, Greece on October 17th to 19th. My name is Simon Geyer. I'm the head of corporate medical marketing of Sigvaris Group. If you have already subscribed to one of our past MOHs, you might have participated in a scientific webinar, or like today in an MOH event promoting a congress or a conference. But there is much more behind the brand MOH, and I'm very much pleased that I have today the opportunity to tell you more about the MOH and particularly about the new format that we have recently published on the MOH platform. With this, I will share my screen. Okay. We have started the MOH Medical Online Hub initiative in 2020 as a reaction to the restrictions that came up with the COVID pandemic regarding travel restrictions and contact restrictions. And initially, it was just planned as a webinar tool to exchange, to give a possibility to exchange with the healthcare professionals during that time. Up to now, we had over 50 MOH talks in 5 different languages that were organized with more than 8,000 attendees around in 168 countries. And but the MOH is also really more than only a webinar. It's a non-commercial educational brand. It's an educational content platform that offers free access to healthcare professionals to first-hand insights with the content that is efficient and sustainable. We have a lot of recordings and written medical articles posted on the platform. Interestingly also is that the content stays attractive over time. Since the first MOH in 2020 about the topic COVID-19 and thrombosis that we started with 800 attendees, we had now up to 5,000 viewers over time in different social channels and on our platform. The content that we have placed in the MOH are different formats, like the one that you know already quite well, the MOH Talks that is including webinars. What I would like to do now is to present you a new one, the MOH Essential, that has been published beginning of this year on the MOH platform. What is the MOH Essential? It's a deep dive into the essential of compression therapy and the veno-lymphatic disorders. The format is that we have experts, compression experts that are presented in videos explaining concepts and various disorders, discussing about various disorders. You will have a library of engaging video chapters and that grow with the field continuously, updated with the latest insights and results. But words are not showing exactly what it is, so I need to quickly go out of the presentation and show you the material on stage. Where is it? So. Can you see the screen?
No.
Okay. I need to try share. Okay, now you should see.
Yep.
Okay. So this is what you see if you go to the homepage, medicalonlinehub.com. This is the landing page. Here you have the events that are currently running, like this one of today, Roads to Athens, Preview Venous Symposium Europe 2000, and some new things that have been placed here, like the MOH Essential. I usually navigate in the MOH platform by using the MOH series. So if I click here, I have different formats that I mentioned before. So the talks, the webinars that you already know. What is also included here is, as example, the MOH Connect, a very interesting format where we have live presentations of workshops that are done with experts together. The last one was with Dr. Erika Mendoza, showing ultrasound and compression application for venous cells. What I would like to show you quickly is the MOH Essential. This is a new format. And we had started a series of videos with Professor Eberhard Traube about the dynamic of compression. And I think easiest is that I show the video directly and let the expert talk by himself.
Welcome to MOH Essentials. MOH Essentials is a new format on the MOH platform. What is it? MOH itself is a new information platform about the whole field of compression treatment. It is presented by well-experienced and international specialists in the field. The new MOH Essentials is like a video book on the complete field of compression, but with content that is not static as usually books are, but it's growing with each new chapter added in the future. These ongoing new chapters are added according to new medical developments and new results in compression treatment. It contains recordings of basic information about compression treatment, but also summaries of important studies and results in compression, as well as state-of-the-art lectures about compression-related topics. What else do we need to say? We need your input. We would be happy if you would enjoy this new kind of education in compression treatment, and please contact us with your ideas and needs for additional topics you are missing. For further updates, you can find us online.
Okay, I hope this gives you just a quick view into what is available on the MOH platform, and please try it out and explore the large amount of content available. But now I have the great honor to introduce our principal moderator of today, Dr. Makis Avgerinos. I don't need really to introduce him, but I will do it anyway because Makis is just a vascular surgeon professor at the University of Athens. But most importantly, in the context of today's MOH topic, he's one of the co-directors of the Venous Symposium Europe. And together with Human Jalai, Tony Gasparis and Nicos Labropoulos, he will transfer the most popular Venous Symposium New York from America to the European area. And I'm very proud that Sigvaris Group can be part of this important event. We will not be organizing only the event of today, but we will also be actively participating at the event in Athens in October. But more about that at the end of the meeting. And now I would like to hand over to you, Makis, for the introduction of our first speakers.
Well, thank you. Thank you, Sylvain, for the nice introduction. And I take the opportunity to thank you both for your MOH session. The platform that you just presented, it's a much needed educational platform. And I think all of us dealing with venous and lymphatic disease and compression, we need to be connected to your platform and keep improving our education. And thank you for doing that. I also take the opportunity to thank you for supporting Venous Symposium Europe. This is the first attempt we are all doing to get it on the other side of the Atlantic. I'm going to have the opportunity to discuss more about it later, but thank you, Sigvaris, for being part of it. With that, I don't want to delay you more. I need to introduce the first speaker, who above all is a friend, but you need to know that he's professor of surgery and radiology in Stony Brook. He's very well known for his expert skills in ultrasound, and particularly as far as venous ultrasound is concerned. He's the founder, if I could say so, of the Venous Symposium in New York, and now he's one of the co-directors bringing the knowledge and the experience of US into Europe. Having said that, we're going to give you like a small pic of what's going to be presented in Athens, and Nicos is going to talk to us about venous ulceration, being a multifactorial disease. Nicos, please take it away.
Okay. Thank you, Makis. It's great to be with so many friends, with Human, great friend Giovanni from Italy, and Silvan. And Now, when we think about venous ulceration, many of us think about reflux and obstruction, but clearly, venous ulceration, for those of you who are expertise on the disease, is truly a multifactorial disease. Now, we look at a venous return. It's aided by the foot, calf, and thigh muscle pumps, the abdominal thoracic pressure changes, and the pressure changes in the right atrium. It is impeded by venous obstruction, which would be intra and extravascular, venous reflux, right heart failure, obesity, and musculoskeletal issues. As you can see here, by the definition of the venous return, many factors play a role. If you look at the chronic venous disease altogether, the things that are important are obviously the reflux, the foot and calf muscle pump efficiency, more importantly, venous wall and soft tissue cellular biology that determine the inflammation and the skin damage and ulceration, the lymphatic compensation, the obstruction, as well as risk factors, which are genetic predisposition, and the rate of progressive disease, which is different in each person. Now, what you notice in various publications, people with skin damage, right, compared to people having less advanced disease, usually older patients have longer duration of disease, more extensive involvement, and higher prevalence of previous thrombosis. Now, what is good on venous disease, the vast majority of the people have superficial vein disease, which is easy to treat, although it's not curable because people develop new disease over time. And we have to notice that the prevalence of skin damage increases with the extent of reflux and obstruction. If you look at the pathophysiology, the vast majority of people having reflux, obstruction alone actually is uncommon, but reflux and obstruction are fairly common. Here we see an ultrasound of a patient with reflux in the sacrophemoral junction, and basically, this by itself doesn't mean much unless you examine the entire limb and you find whatever is wrong. And often, in people with an ulcer, you have to go in the pelvis and see if there's any other, form of obstruction. Here you see a patient with a post-thrombotic popliteal vein reflux. Don't forget about 1 every 3 people with an ulceration that previously vein thrombosis. But people with a vein of the popliteal area, which the gatekeeper having a problem, usually have worse outcomes. Now, another important issue is the chronic obstruction, particularly the iliofemoral obstruction, and it poses a big impact because recanalization failure is more common in these big veins. And there's a failure to recanalize, then you develop significant obstruction leading to swelling, venous claudication, and eventually to skin damage. But if you look at the circulation together, right, all the blood vessels, the development of swelling and skin damage is mostly due to changes, in microcirculation. And because without the exchange surface, really, you cannot live. You can live without the vena cava or the aorta, but you cannot live without the microcirculation. And here is an example of people with an ulcer, and you see, a sample from the edge of the ulcer, and you see all this big, huge network of veins that are incompetent. And if you look at the magnification, look how this vast network of vessels that are not working properly and that cause the damage in the area. And here you can see in a beautiful slide from Greg Jones, a good friend from New Zealand, the microcirculation is that how is affected in the skin area. And what you see with the eye on the ultrasound, it doesn't meet what's really happening in our skin. And don't forget that the microcirculation represents 99% of our circulation system. Why this is important? Well, because there's definitely sites for treatment. Giovanni will talk to you in a little bit about, the effect of the compression. Compression actually is vital to affect the microcirculation, to reduce filtration and inflammation. And of course, you use other techniques as foam sclerotherapy to address the local problems, together with the other techniques to address the reflux and the obstruction. Now, other things that are important is obesity, which affects more than 25% of the population. And look at this huge amount of dollars, like over $500 million, spent, to address this issue. And of course, these people, they are very well known to have more advanced venous disease. Here is an example of a female 63 years old with bilateral extremity and edema. a superficial vein reflux on the left lower limb. You see this huge reflux, right? But normal veins, deep veins, what happened is, look, the patient is a BMI of 46. Look, the CAT scan, the fat, right, is bigger than the content of the body. And what happened is, this people have very dilated vein, is slow flow, that the obesity, creates what we call a form of functional obstruction, and it leads to skin damage without even having a reflux. Another big issue is the static foot disorders. People having, flat feet or hollow feet, and this impedes the ability of the muscle pump to inject the blood back to the heart. And there's a nice paper by Padberg from New Jersey showing that the limited range of motion in the ankle, has a high association with, ulceration. And this could be because of bone issues, or because the people may have, stroke, neuropathy, trauma, or arthritis. Here is another example of male 65 years old with bilateral low extremity, skin damage. What is interesting, this means pulsatile flow in the deeper superficial veins in the standing position. Look at the standing position, the femoral and external iliac, and the saphenous vein, pulsatile flow. Why is that? Because the problem of this patient is actually the right heart failure. So to finish, giving you a small taste of what you can see in people with skin damage, chronic venous disease is multifactorial. Many factors involved, particularly in patients with skin damage. These factors are very common. We should see the patient as an entity and not just the disease. Consider all the factors and prepare a good treatment plan. And obviously, set the patient's expectations correctly from the beginning. Thank you very much.
Nicos, excellent presentation, very well said. It's not about reflux. We have many colleagues treating great saphenous vein reflux, and the patient continues having symptoms. It's the microcirculation, it's the obesity, so many other factors that come in, and we need to see the patient holistically. Having said that, I can kick off the discussion. Tell us a little bit about the perforators. You said that 35% of patients have reflux in the perforators. Are the perforators alone enough to create an ulcer or to create edema, or not? Something else also need to coexist.
Now, Mike is a very good point. I think that's a myth. The perforators by themselves cannot cause any of this because the volume shifted from the tiny diameter of perforator is not enough to create the damage. Usually the conjunction with a vast network of superficial veins and the post-thrombotic disease, of course, with a deep venous system as well. But the perforators alone can cause anything.
Agreed. Any question from our panelists?
I just checked the chat and also the Q&A, but there is nothing yet. So I encourage once again the audience just to ask the questions directly in the chat. So we will answer there afterwards.
I can keep asking Nicos. Now I'll take the opportunity to educate myself. You talked about the microcirculation. It's 90% of our circulation, and you discuss about the importance of compression. It definitely makes sense. So compression up to the knee or compression up to the thigh, is it the same?
There are very few studies on this shown similar outcomes, and because the compression below the knee is better tolerated and applied to the patient, so people prefer to do this. And in fact, it's better to use that compression below the knee than having no compression at all. But what is more important, Mike, is that Giovanni will explain, is to use the appropriate compression for the right patient. To me, that's important. And since you mentioned the microcirculation, if the microcirculation is not affected, even have reflux or obstruction, then you don't get any signs and symptoms. You get those because there is an issue with the microcirculation, basically. And quite rightly, if you look, with an open MRI in static position, the compression is not going to affect the diameter of the vein as people naively think. What it does, though, it addresses issues on the subcutaneous space, in particular microcirculation. And that's why, to me, is very important to use this treatment effectively with a good know-how like Giovanni in the right patients.
Dr. Mosti, you need to comment on that.
Nicos, may I have first a question for Nicos? Nicos, you speak about all these other factors beyond the venous insufficiency, but regarding, for instance, obesity, ankle all these joint disorder, they are anyway causing venous hypertension. It is not anymore an ambulatory venous hypertension, but it's hypertension or stasis, if you like. So at the end of the day, they are still venous, even if with a normal venous system. What do you think?
I agree with you entirely, because it is, since this impair the ability to eject blood to the heart, right? Then obviously you're gonna have, the blood staying there for, in a certain amount of time. And the states that you mentioned as well is gonna allow change the microcirculation over time, like fluid leaking out, red blood cells leaking out, hemosiderin, and leading this all inflammatory cascade, which unfortunately, there's only one paper. It's a beautiful study by Dr. Marston, showing that when you apply compression, proven by a biopsy, you reduce inflammation.
Yeah. There is the two studies about by Beidler, that's the group of Marston. Very nice study. Yeah, you're right. And regarding a thigh or knee compression for venous ulcer, I know that thigh compression in these cases is completely unrealistic. Everybody will apply knee-length compression. It is not so easy to convince patients to have compression on their leg, and they certainly wouldn't accept to be bandaged or compressed up to the thigh. It is already enough. And on the other hand, compression up to the knee is very effective, so I do not see any reason to extend the compression to the thigh.
Thank you, Dr. Mosti. And I think it's time to move on to our next speaker.